You are officially invited. Yes, you're invited to join us in Fertility Awareness Mastery. This is my 10-week program designed to help you gain confidence using fertility awareness. Whether you're actively avoiding pregnancy or looking to optimize your cycles for conception, we have a spot for you. We start on January 22nd. Are you ready to jump in? Head over to fertilityfriday.com/group program to reserve your spot today. That's fertilityfriday.com/group program. This is the Fertility Friday podcast, episode number 233. Welcome to the 233rd episode of the Fertility Friday podcast. Thank you for joining me today. I'm Lisa from fertilityfriday.com, and this is your source for information about the fertility awareness method and all things fertility. In today's episode, we are welcoming back Dr. Jerilynn Pryor. For those of you who have listened to the show for a while, you'll remember Dr. Pryor from episode 55. And that was one of my early episodes, and it was a really powerful episode. What I really like about Dr. Jerilynn Pryor and her work is that for a significant period of time, Dr. Jerilynn Pryor has been researching the menstrual cycle and specifically the effect of progesterone beyond your ability to procreate. And in our first episode together, we really talked about why regular ovulation is essential for health, particularly bone health, heart health, and breast health. It's a fascinating episode because it really takes us into a different territory when it comes to the menstrual cycle. It takes us away from the myth that the menstrual cycle only matters when we're trying to have babies and it has, nothing to do with our health, and shutting it down with hormones has no impact on us, outside of the fact that it makes it such that we can't get pregnant. But all of those are just simply myths. And that's what I really appreciate about Dr. Pryor's work, because she really shines a light on the importance of regular ovulation, and in particular talks about the role of progesterone outside of reproduction, which is fascinating. And so there's several incredible tidbits in today's episode that I know you're going to enjoy. So I'm really excited to share it with you. And if you've been thinking about adopting the fertility awareness method in your own life, if you're ready to move towards fertility awareness for birth control, if you've been thinking about coming off hormonal birth control, or even if you've been charting for a while, but really want to feel more comfortable and confident in the method, then I encourage you to head over to fertilityfriday.com/group program and take a look at the 10-week program. We're going to start a brand new 10-week group program in January. We're going to have our first session on the 22nd. This time I'm planning to do one group. We're meeting on Tuesday nights, 8:30 p.m. in the evenings. And if you want to join us, make sure to head over to fertilityfriday.com/group program and apply so that we can make sure to save a spot for you. Because I'm only doing one group, there are a limited number of spaces available, and the group usually does fill up. So if you're thinking about it, if you're wanting to join us, make sure to apply early so that we can make sure that we have a spot for you. And again, that's fertilityfriday.com/group program. Now let's jump into today's episode with Dr. Pryor. And I'm very excited to welcome my guest, Dr. Jerilynn Pryor, back to the show. Dr. Pryor is a professor of endocrinology and metabolism at the University of British Columbia, working on women's health. She studies menstrual cycles, the effect of ovulation and its disturbances on women's later life, later osteoporotic fracture, heart attack, and breast cancer risks. She is the British Columbia Centre Director of the Canadian Multicentre Osteoporosis Study, and that is a 20-year prospective 9-center population-based bone and general health study. And she's also the scientific director and founder of the Center for Menstrual Cycle and Ovulation Research. And so in today's episode, we're going to be talking about the importance of ovulation for overall health. And so without further ado, welcome back to the show, Dr. Pryor.
Thank you, Lisa.
Well, I'm so happy to be speaking with you again. We were trying to figure out how long it's been since I had you on the show, and I'm not sure exactly, probably about 2 years or 2.5 years or so. So I'm sure the listeners can go back to our first episode to hear more of your history and kind of what brought you into this work. But maybe we could just start on the topic of ovulation. And so you've been researching in this area for quite some time. And maybe you could share with us why it's kind of continued to be such an important area of study for you, and why you continue to work in the field of raising awareness about the importance of regular ovulation.
Okay, it is an old story and a long one, but basically, I began to study women's menstrual cycles because as soon as the women started doing more intense exercise, running longer than 5 kilometer distances, running marathons, now we're talking about the 60s, all of a sudden there were a whole bunch of cross-sectional studies saying that basically that running was bad for women's reproductive health. And I strongly questioned that and the methodology in the studies. And so I began to try to figure out what would be the best way to look at that, and ended up deciding that we needed to take women in whom we had proven 2 consecutive normally ovulatory cycles, and then observed this whole group of women, some of whom were sedentary, or, well, in those days, Vancouver being an active city, it was pejorative or negative to say someone was sedentary, so we called them normally active. And then some were running just for their health and general well-being, and some were running and training for a marathon. So that's what we did. We documented ovulation in those cycles by a quantitative basal temperature method that we'd validated and developed. And what we found was that cycle length almost didn't change at all across the full year within each woman, but the length of the luteal phase and whether or not they ovulated, in other words, the length of the time from ovulation until the next flow, and whether or not they ovulated at all, was where all the variability was. And it happened that I wasn't able to get funding for that study until I said, I'm going to measure bone density because, women training for a marathon, if they become amenorrheic, they lose their periods, they're going to be losing bone. So we had measured bone, and what we found was that 20% of the variability of the change in bone was accounted for by the average length of the luteal phase over that 12-month period. And that's huge. Well, actually, it was 23% that was related to the relationship of luteal phase length to cycle length. So ovulation was the main reason for a change in bone. And in fact, the 13 women in that out of 66 in that study who didn't ovulate in 1 or more cycles were losing about 4% of their spinal bone.
Well, and it's one of, I think that for women, there's a lot more talk in this space, as I'm sure you can appreciate being in this space for as many years as you have. So a lot more women now are talking about the importance of regular ovulation for health, to try to move away from that whole concept that the only time your menstruation and your regular ovulation matters is when you're trying to conceive.
That's right. Yeah.
And so just making that connection between regular ovulation and bone density, to many women for whom this is the first time they're hearing that, it just seems crazy. Like, how could we not know that there's actually a link between our menstrual cycle and how our bones develop? Meaning that if we don't ovulate regularly, we're actually at an increased risk for, bone fractures or osteoporosis later in life. Maybe you could just talk a little bit about that, because I feel like it really brings home why ovulation is important for more than just making babies.
Okay. Well, for a start, let's put the confusion out there. Many doctors consider that if you have a regular cycle, it's within the normal range, 21 to 35 days for usual cycle length. And you can say my usual cycle length is 29 days or 26 days or whatever, then you're always ovulatory. And that is, in fact, what gynecology has predominantly taught doctors for decades. And so the gynecologists will often use the term anovulatory when they really mean that the cycle is irregular or longer than it should be, or skipping periods. So the word anovulation may be used in the scientific literature in a way that's inaccurate. That's talking only about cycle length. But when I say that anovulation, I mean that they didn't release an egg and their progesterone levels didn't go above the low levels during the early part of the cycle. So I guess it all stems from the definitions of, how we think about estrogen and progesterone. When you look up the official definitions of those words on Wikipedia, for example, estrogen is important for normal fertility and for general women's health. It relates to bone, it relates to heart disease, to brain function, blah, blah, blah. Then they say progesterone is essential for fertility, period, full stop. In other words, the concept is out there that estrogen, largely because it was touted as a therapy in menopausal women for many years, that estrogen is related to the whole body and to lifelong health, but progesterone is for fertility.
Mm-hmm. Well, and it's so interesting because if you think about your body as like a circulatory system where, you're producing hormones, it's not like they just hang out by your ovaries, right? Like these hormones go throughout your whole body and you have receptors for progesterone in all kinds of places, not just within your reproductive system.
That's right.
One of the things that I found when I was looking through the literature is that I found what you're saying. And I felt like I could feel your frustration after all these years, because so many researchers speak exclusively of estrogen when they're talking about bone density, and they don't even mention progesterone. It doesn't even come into play. So even in terms of the scientific research, if you're doing a study based on the assumption that only estrogen does anything, then you wouldn't necessarily even think to test progesterone and even look into that, the possible effects.
Especially if you assume that a regular cycle is always ovulatory and always releases enough progesterone. Well, the good news now, and it has taken 25 plus years to get here, is that there is now strong scientific evidence that progesterone prevents osteoporosis and is effective for treatment. So I published a review in the journal Climacteric just this summer, and it's open access, so anyone can look for it. If they look for my name, Climacteric 2018, it should come right up.
Well, and so maybe you could share with us, there's one question that I have, and I'll try to make it like not convoluted, but a lot of women are concerned about low progesterone. It's almost like a buzzword. So especially for women who are trying to get pregnant and they start to learn about the menstrual cycle and fertility awareness and how you can actually track your cycle and identify how long your luteal phase length is and all of those types of things. I just have a question about, because there's a difference between anovulation, meaning that you didn't ovulate, and then obviously you didn't produce significant progesterone that cycle. There's a difference between that and actually ovulating, but having an issue with your luteal phase such that you're not necessarily producing enough progesterone. And you mentioned that in the study that you were referring to, 20% of the bone loss, correct me if I'm wrong, was related to how long the luteal phase is. So for example, if a woman has her progesterone tested 7 days after ovulation and her progesterone level looks fine, but then she only has a 10-day luteal phase. You see what I'm asking? Because then she has fewer days of progesterone that is optimal. Maybe talk to us a little bit about the concept of low progesterone in the cycle and how the number of days in the luteal phase makes a difference. We could talk about for fertility, but outside of fertility as well.
So for fertility, what I use, and it's based on the quantitative basal temperature method that we use, 10 days is the minimum normal, and it can be normal up to 16 days of a high level of progesterone. And that's necessary because it takes a number of days before the lining of the uterus can be changed from a proliferative, juicy kind of endometrium into one that has secretory glands that's ready to accept and help fertilized egg grow. And it's likely that the same duration effect of progesterone is also in other tissues, including in bone. And that is, in fact, what the study I was telling you about showed. Those who had short luteal phase were losing about 2% of their spinal bone density during that 1 year. And those who had any anovulatory, no progesterone production, had 4% bone loss.
Mm-hmm. Well, I think that's so interesting. It's both interesting and important because, what you're saying is you can have regular ovulatory cycles, but if you're not necessarily producing sufficient progesterone, you can still be having a negative effect if you're not getting enough of it.
That's true. So then it brings us back to what are the things that are related to not ovulating normally. And actually, I lump short luteal phases and anovulation together as ovulatory disturbances. And in fact, I call them silent or subclinical ovulatory disturbances because you can't tell unless you're actually doing something actively to figure it out whether or not a cycle is ovulatory if you're an average woman. So the things that are related to a silent ovulatory disturbance are extremely common and extremely subtle, and they are particular for each woman. But in general, they have to do with emotional, nutritional, physiological, and medical health. So if a woman is under stress, say, because she's in a low-paying job and she has to get a babysitter and she doesn't have somebody for a backup if her kid is sick and she's barely making the rent if she works as many hours as she's supposed to, that kind of a situation, that is enough to cause the luteal phase to be shorter than normal or to be absent. Or the person may be carrying on fine, and then something happens like she gets sick, and she doesn't have sick leave coverage, or something like that. Another situation is somebody who's doing in a very successful job, but who's being sexually harassed or abused related to her sex and gender. And if I were to try to boil down what I think, it is that the majority of the reasons for not ovulating normally are because women have a lower status in this culture than men do. And that reflects itself in our lower wages. It reflects itself in our double jobs, the care for children, elders, and others in our family, sometimes partners as well. In other words, feeding and laundry and shopping and all that stuff. And it has to do with how we're treated in our professional or our work lives. And those things together, especially if we don't have social supports, are enough to cause ovulatory disturbances.
It's really interesting, the connection that you made there, to really flesh out the different stressors that many women experience and how it can specifically not only relate to their cycles, but kind of the broader issues that can arise with insufficient progesterone.
Yeah. I mean, our mind and our bodies are not separate. And I think the most incredible example of that is the variation in the length of the luteal phase. It's incredible how much of a reflector it is. It's like the canary in the coal mine.
Mm-hmm. Well, when I'm teaching women to chart, their cycles, I mean, one of the first things that you learn about the menstrual cycle is that the luteal phase is the most stable. So of the two. So we have the pre-ovulatory phase before ovulation, the post-ovulatory or luteal phase after ovulation. And if you were to look at, extensive population data from thousands of women, you would see that before ovulation is definitely more variable. So if you're going to experience variations in menstrual cycle length, it's going to be typically, for the most part, due to the pre-ovulatory phase. But I think what most women don't necessarily realize is how the luteal phase can vary as well. So the luteal phase isn't going to vary like 20 days because it, typically is up to 16 days or less. So the variation is going to be smaller, like a couple of days. But it can vary a lot. So maybe talk to us a little bit about that in terms of the variations you've seen and why a variation of 2 or 3 days in the luteal phase would make such a big difference.
Okay, I guess we have to go back to the actual amount of progesterone. One of the things, again, that people don't realize, largely because of the Google images that make it look in a diagram of the menstrual cycle, that estrogen and progesterone peaks are about the same, or maybe the progesterone peak's a little lower or maybe a little higher than the estrogen peak. Well, that's actually quite wrong. And those images don't have any units on them. In fact, estradiol rises about 150% above its baseline in the follicular phase. Yeah, maybe it's 250%. Yeah, 250%. But progesterone rises 1,500%, 1,500% higher. In other words, there's a huge amount of progesterone made. It's in nanograms or nanomoles per liter, and estradiol is in picomoles, which is 1,000-fold smaller unit. So in other words, there's this huge amount of progesterone made. It must have a purpose. It must be an important thing for the body to have, or it wouldn't make such large amounts. And yet, it's also a very costly thing for the body to do, because whenever our luteal phase progesterone is present, it takes energy in that circumstance because our temperature goes up 0.2 of a degree Celsius or 0.3 of a degree Celsius, and it takes energy to raise that temperature. So we eat about 200 or 300 calories more whenever we're in the luteal phase range. So you can imagine if we're in a situation where food is scarce or there's food insecurity, one of the first things that would happen was that we would keep our cycles, but let the luteal phase thing go, because it's not a good idea to get pregnant if you can't eat enough to adequately support the pregnancy.
That is so interesting. I've never heard that before, that you actually eat a little bit more, require a little bit more energy to support the raised temperature that occurs after the progesterone.
It makes sense, doesn't it?
It does. Well, and then there's the lived experience of many women during that phase of having more cravings. So do you feel that there's a direct link there because of this increased energy requirement?
No, I think the cravings are higher estrogen. But yeah, or a little being in touch with our true feelings or something if we're luteal. If we're ovulatory. But so we've talked a bit about bone, but what I've learned since is that there's any place in the body where there's an estrogen receptor, and that's basically everywhere, there is a progesterone receptor, because the two hormones are meant to work together. And again, in terms of a concept, my concept is that estrogen is a powerful and very important growth stimulator. It's actually an important growth stimulator in older men as well as women. Just like women have testosterone, just like men do. Men have estrogen just like women do. But growth, if it carries on unchecked, carries the risk for malignancy. and you wouldn't want to continue growing and be 25 feet tall or something. So there needs to be some check on that growth. And estradiol's check is progesterone. Its job is to cause the tissues to become differentiated or mature, which is an anti-cancer effect. So I think of the two hormones as working together in every tissue, in every cell, throughout women's bodies. And that's why we have the 35 to 45 years in which we have menstrual cycles, is to allow those two hormones to work together for the sake of our bones, our skin, our cartilage, our brain, our heart, our breasts, and every tissue in our bodies.
Well, and this, this perspective is not what we as women grow up hearing about our menstrual cycle. We grow up hearing essentially that, you start menstruating when you can have babies and that's it.
Yeah.
To me, it feels like there's this idea that your menstrual cycle happens in a vacuum or something. The hormones that are produced during that time have no impact on any of our other bodily tissues. And we're at the point where it's, for 50 years, it's been standard medical practice to administer hormonal birth control to suppress the natural cycle. And, as far as I have heard from interviewing several doctors and, all of these years of being in this field, it would seem as though many medical professionals see absolutely nothing wrong with shutting down that perfectly natural and healthy process. So, Dr. Pryor, where did we go wrong? How could medicine have it so wrong in the sense of...
Yeah, exactly. And in fact, there's now evidence, again, that is extremely hard to publish, but that birth control pill use or combined hormonal contraception use, it could be the patch or the vaginal ring as well, when you're within the teen years, has a negative effect on your growth of bone to its peak. And growing a peak bone mass is essential for preventing fractures when you get older. So we did that. We found that in the Canadian Multicentre Osteoporosis Study, that those young women who were 16 to 19 who had used the pill, and it was about 65% of those women over the 2 years, were gaining significantly less total hip bone density when we didn't adjust for everything. When we adjusted for everything, then there was still a trend toward negative effects, especially on the femoral neck. And
the femoral neck,
another,
just so that...
Yeah, I mean,
is that the femur and the leg?
Also published, the hip joint.
The hip joint.
Yeah, that is also published and is open access. I got to spell the name of the first author. She's a new Canadian physician in the process of becoming a clinician here, and she worked with us at SEMCOR on it. Her last name is spelled Brajic, and it's in the Journal of Musculoskeletal and Neuronal Interactions I think it was actually published in 2018. So it's worth looking up, or you can put in CaMos, CaMos, plus that last name, and it should come up.
Well, and I'll make sure that we link to the papers that you're referring to as well.
That's great. Yeah, that's good. So, and we've done a meta-analysis of all the publications that have actual data about bone density change when women were taking the birth control pill, adolescent women, compared with controls from their own community, actually from 3 different countries, USA, Canada, and China. And the results show a highly significant loss of bone in those women who were on the birth control pill when they were teens. This is spinal bone density than those who weren't. So it's a very important thing. And the problem is that women, when they see the doctor, aren't given other options for things like cramps or things like irregular flow, which might be normal or which is normal in the first 2 years after your first period, or for pimples, which are normal in the first few years. So young women need to know that there are options besides going on the pill if they're miserable with something related to their cycle when they're a teenager.
Mm-hmm. Well, and I mean, what you're talking about, it really just speaks to how important regular ovulation is for health in other ways. But there's it shatters that idea that your menstrual cycle is only important for reproduction. You know, yeah. I always refer to it like it's as if the medical profession got together and decided that our reproductive organs were kind of like this add-on, like when you buy a car or something and it's like, do you want AC? Because you can get a car without AC.
Do you want cruise control?
Yeah. But I think like, when are we going to get that this isn't an add-on. So it's actually a fundamental part of us. And as you mentioned, we have receptors for both estrogen and progesterone throughout our entire bodies and in all of our tissues, not just the reproductive ones. And so therefore these hormones have a purpose. Yep. So we've talked about bone density, the impact. I'm not sure if there's anything else you wanted to talk about related to
indeed.
That. Okay.
I want to talk about heart, because there's evidence from a large study. Actually, they used a mammography population in the Netherlands, and basically they asked women who were, I think they started doing mammograms at 40, but the average in the population was, the age was 45. They asked them if they would collect a urine on day 23 of the menstrual cycle in 3 consecutive cycles, and the investigators picked them up and stored them from thousands of women. And then they kept track of all the young women, or these youngish women in the community who had a heart attack and were admitted to the hospitals in the local region. And after they had enough women with heart attacks, then they went back and they chose 3 out of the whole population of women's samples as controls for each of the women who'd had an early heart attack. And they measured estrogen in the urine, progesterone in the urine, and testosterone in the urine. And they expected that the estrogen would be lower or the testosterone would be higher. But they found that wasn't true. What they found was that progesterone tended to be lower. But if they eliminated from the group all of those who had non-ovulatory cycles by the urine progesterone level, there were many more non-ovulatory cycles in those women who'd had a heart attack than in the controls who hadn't. So that's evidence that you need normal progesterone in order to prevent heart attacks in women very early in menopause. And there's similar data from a monkey study, actually. In the monkey study, they housed monkeys, like 5 or 6 female monkeys and 1 male monkey that had had a vasectomy, and fed them all sort of a high cholesterol, typical Western type diet for 3 years. And I guess they had some, university students who were studying psychology who were working on the project in the summertime. And they noticed that there were some of the female monkeys that were the dominant ones. They got more grooming. They got the food first. If there were disagreements, they seemed to win the arguments. And there were a few, like 1 or 2, that were dominant, and the rest were subordinate. They all were well fed. They all had similar cycle lengths, but the subordinate monkeys weren't ovulating consistently. or they had many more non-ovulatory cycles. So when they finished the study and they examined the tissues of those monkeys, they found that the male monkeys had lots of plaque in their big arteries. They found that the dominant female monkeys had clean arteries in spite of the high cholesterol diet, but that the subordinate monkeys had similar amount of plaque in the arteries as did the male monkeys. And they also found that the subordinate monkeys had larger adrenal glands, so showing that they were under stress. So stress causes ovulatory disturbances, causes abnormal arteries or early heart attacks. That's pretty scary.
Mm-hmm. Yeah, no, it's just so interesting. And as you were describing the first study, when you said that they tested the urine on day 23, so as a fertility awareness educator, of course, I know that by day 23, they're assuming that the woman should be past ovulation, right? Like somewhere in the middle of her luteal phase. Yep. But many women don't ovulate on time. And many women experience cycle variations and fluctuations and all of those types of things. And so one of the questions that I'm sure you've pondered over the years, so, when I look at just based on everything that I've come to know over all of this time, if a woman is experiencing cycle fluctuations, it's typically a sign of something else. And there's a well-established link between irregular menstrual cycles, such as that seen in women with polycystic ovarian syndrome, and cardiovascular risk factors. And so the question is, did the chicken come before the egg or the egg come before the chicken? Is the menstrual cycle disruption an indication of the actual underlying problem, which would be, in that case, those cardiovascular risk factors?
Well, in this case, it wasn't, because they didn't have PCOS. Their androgen levels weren't high. And when you study thousands of women, they're unlikely to all have irregular cycles. The majority would have regular ones.
Well, if you're testing day 23 progesterone, and then the women who had lower progesterone or hormones, and the women who had lower progesterone were also more likely to have these risk factors. I suppose I'm just asking, is
no,
it?
They didn't seem to differ. In a big study like that, they'll have age, height, weight. It was a mammogram study, so they didn't have as comprehensive a data set as other studies might. But there wasn't any indication that there were a stacking of risk factors in a particular set of women. And the only difference that they could show was that fewer of those women had ovulated about 8 years before.
Well, and so then there was no reason for the ovulatory disturbances?
There was a reason, but it wasn't measured in the study.
Okay, so the study just didn't report on the why, it just reported on the what.
That's correct.
Okay.
So most of the time that's the case. And very few studies have actually looked at why there's ovulatory disturbances.
Mm-hmm. Well, and I suppose that's the unanswered question that we have, and that's kind of the question I'm putting forth, which is that if a woman is having ovulatory disturbances, from my understanding, there's a reason. There would be some reason that would be causing that. And would that reason potentially be linked to her increased cardiovascular risk factors that she's showing?
Well, the reason is the stress, and you can play it that way, and you can say, like in the monkey study, is it because of high cortisol that she's having the heart trouble? But there hasn't been a clear association made between higher cortisol. I think that the effect is through the progesterone, and one of the reasons I say that is because this is a bit complicated, but bear with me a second. There's an important system called the endothelial system that controls blood flow in all our blood vessels. And there's release of nitric oxide from the lining of the blood vessels. And one of the reasons that we have thought for years and years that estrogen was so important for heart health is that estrogen makes blood flow better, improves endothelial function. We did a study here, and I can give you the reference because it isn't open access, but in which I think it was 24 healthy menopausal women had the test of endothelial function when they were given estrogen, when they were given progesterone, when they were given estrogen and progesterone, or when they were given a vehicle. And they had the test once a week over 4 weeks. So when we looked at the data, what we found was that progesterone was the only hormone combination that was significantly different in increasing blood flow than the vehicle. And estrogen and progesterone were almost identical. So progesterone works on this fundamental part of the vascular system, just like estrogen does, suggesting that it's playing a role in the cardiovascular system.
Mm-hmm. So, I mean, this speaks to the importance of regular ovulation for health, as we've been talking about. So for a woman who's listening to this and recognizes perhaps maybe she's charting her cycles and she recognizes that, maybe she has a shorter luteal phase, or maybe she's got really long cycles. So she's not necessarily having, so for instance, if you have a longer cycle, if you're closer to the 35-day end of a total cycle, you're going to have fewer periods a year and fewer days of progesterone production, cumulatively, if you were to add that all up throughout the year. So has your research kind of gone into the area of what can we do to improve how much progesterone we're having, or is there a way to do this naturally, or do we, what do we do?
Okay, good question. Here's what we know. There have been 2 randomized studies now that have shown that a mindfulness training program improves both cycles and ovulation in women who have what's called hypothalamic amenorrhea. In other words, no periods for 3 or more months, not due to PCOS, not due to an ovarian disease of some sort. Okay? So, in other words, practice of mindfulness meditation is likely to improve a person's own menstrual cycles and ovulation. I personally think that learning about the cycle and tracking the cycle improves ovulation. I can't prove that, but we did a study in women who had a collection of different disturbances. Some had amenorrhea, some had oligomenorrhea, far apart periods. Some had regular periods without ovulation in 2 cycles in a row, and some had regular periods with short luteal phases 2 cycles in a row. And we gave those women cyclic progesterone with additional calcium, or cyclic progesterone with a placebo calcium, active calcium only, or both placebos over a full year. And what we found was that almost half of them recovered normal cycles and ovulation. So we couldn't attribute it to a change in weight. They were all normal weight at the beginning, a change in exercise, a change in the calcium, or a change in the progesterone. And so therefore, I think what was really going on was, as they learned more about themselves, their cycles recovered.
And maybe the progesterone helped as well?
We couldn't show it statistically. It helped the bone, but in terms of recovery of their cycles, we couldn't show that there was a statistical relationship with progesterone.
Well, and it's interesting. I've experienced, so let me just kind of take what you said in terms of, does tracking the cycle itself and paying attention to it improve the parameters? So what I've observed is that when it's kind of like anything you observe. So if you were to write down everything you eat for a month, your eating patterns might improve too, because all of a sudden you
Sure.
are writing it all down, and you see some things that maybe you don't want to be consuming as often, and it's brought to your attention. So maybe you clean it up. Do you think that there's some degree of that going on?
Absolutely.
Because I know when women start tracking their cycles, they want to see those cycles look healthier.
I think it's by the time a woman says, I want to understand what's going on with my own cycle for whatever reason, for fertility or for health or for curiosity or whatever, I think she is facing something that is taboo in our culture. In other words, there's a sort of a cultural attitude that a young woman's periods belong to her gynecologist or her mother or her partner or somebody, and not to her. And that obviously that's not true, but there's a sort of a way in which we live in our bodies but don't own them as women. And once we start owning them, then we pay attention and take better care.
Mm-hmm. I love that you said that, because I've never heard it put that way. But when you were saying it, yeah, because we don't know anything about our cycles, really. The vast majority of women I've spoken to over the years weren't taught. So they kind of were in a similar boat as myself. There are a few women who, and especially more now, whose mothers or maybe someone else in their life taught them about their cycles. But yeah, it's almost like they do belong to someone else, because we don't understand how they work. We're given very little information about them, and we're not even told that it matters for our health.
Yep. So those three things, understanding how it works, understanding that it matters, and being given permission and tools to learn more about them, are the start of healing of menstrual cycle and ovulatory disturbances.
That's really interesting. And I mean, it really underscores the effect of stress. And it's so hard. I find that it's challenging talking about stress as women. I think you mentioned this at the beginning of our conversation today, or maybe I was listening to something. It could have been. But just in general, as women, we are often the caregivers. We're often the ones giving of ourselves, of our time, of our affection, of our services, often not, not necessarily compensated, right? The 76 cents on the dollar, I think it is in Canada, or something like that. And so then it's hard. I think it's hard to put an already stressed population, and then you tell them, like, manage your stress. But at the same time, it's so important. How do you manage those messages?
It's hard. It's you need a sense of humor, and you need other women to joke with. Yeah, but talking about it is really helpful. Mm-hmm. Having other women who are willing to talk about it is helpful. I mean, I probably went into this area of research and became a physician because I was, well, for example, when I first went away to college and university, I lost my period totally. And I knew I wasn't pregnant, and I knew I was eating well. So it had to be stress. And I never told anybody. I went home and worked in the summer, and my period came back. So, that women like me, and I was an outgoing and, had lots of friends and lots of family, that I didn't tell anyone is important. I should have talked to somebody. I should have explained what was going on. And so the more we talk about it, the more we understand about it, the more we own our own experience, the more empowered we are to improve the things that can be improved. And it's about time that we start improving a culture that makes life really miserable for too many women.
Mm-hmm. Well, I mean, we've talked about so many different topics today. As we bring our conversation to a close, what is the biggest takeaway or the one thing that you'd want to leave the women listening with?
If you're a person who's having disturbances in your cycle or in ovulation, just remember that the body is your whole self is incredibly resilient. And when you feel at home with yourself, with your body, with your future, with your dreams, then everything will become normal.
Well, wonderful words to end on. Thank you so much for being here, Dr. Pryor. It's always a pleasure to talk to you and to hear about your research. I'm always very happy to know that you're out in the world raising awareness about the importance of regular ovulation.
Thanks, Lisa. I'm glad you're there too.
Well, thank you. Well, because I'm sure it's interesting. I'm in the middle of my career, and I just wonder what it's going to be like in the next 20 years. And I really hope that we're going to make some progress.
I do too.
Well, and so we will connect, and I'll make sure to get the links to those research papers that you were talking about. But for the listeners who want to find more about you and your research, where can they go?
Center for Menstrual Cycle and Ovulation Research website. So it's www.cemcor.ca.
Perfect. Well, thank you so much for being here.
Okay. Thanks, Lisa.
Thank you for listening. If you enjoyed today's show, please share it with a friend. You'll find the show notes for today's episode over at fertilityfriday.com/233. I hope that you enjoyed today's episode with Dr. Pryor. Always a pleasure to have her on the show. And as I mentioned at the beginning of the episode, before we jumped into everything, I really do appreciate her perspective on the menstrual cycle. And, she's been doing this for a long time. She's done a lot of research in the area. And I think it's just really fascinating and really important to add this to the conversation about why the menstrual cycle is important for overall health. And of course, very, very interesting to learn about the progesterone kind of balance to estrogen. I know Dr. Pryor has talked to me about that before, how when we're looking at the very common images of the menstrual cycle showing estrogen in the pre-ovulatory phase and progesterone in the post-ovulatory phase, it gives us the sense that, these hormones are about equal, but really they're not equal. We're producing, significantly more progesterone in terms of the actual amount that is secreted. And that really just lets us know and gives us an indication of how important progesterone is for overall health. And the fact that we don't produce it, basically at all, unless we're ovulating, we would produce a very low level of it, but we're not producing progesterone in significant quantities without ovulation. So, if we're producing that much of it, then, it must be there for a purpose. And I just love this conversation because it takes us into the realm of why our cycles are important. And it's so ironic as women that we have to fight to menstruate normally because that's just what our bodies would do, right? That's just the natural function of our bodies. So it's kind of strange. It's kind of the opposite to what it should be, that it seems like we have to kind of fight to menstruate because, as soon as there's a health issue or anything related to the menstrual cycle, medical professionals are very keen to put us on hormonal birth control to kind of quote unquote, regulate it. I hate that word, hate that term, hate that phrase. But of course, that's the common way that we talk about that within the medical world, which is, we're going to put you on hormonal birth control to regulate the cycles and, fix those irregular periods or whatever the case is. And it's so ironic that it seems as though we have to kind of fight just to not be on those hormones and to ovulate and menstruate normally. So I hope you enjoyed today's episode with Dr. Pryor. I know I did. I always enjoy having conversations with her, and I love talking about the menstrual cycle and, of course, why it's important for health. And so if you're not part of our Facebook community, make sure to head over to fertilityfriday.com/community. We will definitely be talking about today's episode and what your takeaways were from it. If you're ready to jump in and take your fertility awareness knowledge to the next level and really gain that confidence and comfort in your ability to chart your cycles and rely on it for birth control or to optimize your chances of conceiving, even to delve into your cycles and determine what we can learn from it, what your cycles are shedding, the light that your cycles are shedding on your overall health status, if there's anything we should be looking at, make sure to head over to fertilityfriday.com/group program and take a look at the upcoming 10-week Fertility Awareness Mastery Group program. We will be starting in January, and that is really just a few short weeks away. And so I'd love to have you in there. Make sure to head over to fertilityfriday.com/group program, put in your application just to make sure that we have a spot for you. Because I'm only doing one group, the spots do fill up fast. Each group that I've done in the past year has sold out. And so I just want to make sure that if you're wanting to join us, you have a spot. And I just want to thank you for spending some time with me today, for tuning into the podcast. I really appreciate you for being part of the Fertility Friday community. I appreciate all of you for sharing the show with your friends and really spreading the word about fertility awareness. I really feel like we are making a difference, making an impact, and shifting the way that we're looking at the menstrual cycle, really recognizing the importance of healthy ovulation, healthy regular menstrual cycles, and why it's important, and also what you can glean about your overall health by paying attention to your cycles. So I really appreciate you for being part of that movement. And with that said, I hope you have a wonderful weekend, whenever you are listening to the show. So thanks again. And as always, be well and happy charting.